That's not good. Well, I turn the camera on.
Senator Katie Hester.
Hello.
Please turn up the volume.
Can someone confirm that you can hear me?
We can hear you.
I could hear you.
Thank you.
Someone wants to join. Okay. Well, good afternoon, everyone.
Good afternoon.
Good afternoon.
Hey, everyone. Senator,
Good afternoon.
we're going now live to the outside world. Yes. Okay, just wanted to verify. Okay. Well, we'll get started. Good afternoon. Those who are not on the meeting Zoom call, Wade Rutherford, and we're kicking off this afternoon. I want to thank everyone for joining us for the first virtual meeting in Maryland. Our last meeting was in mid-February, just before the coronavirus had taken hold and hit the U.S. in a big way. We were scheduled to host a meeting in Southern Maryland in March, but of course that was canceled as a result of the pandemic. And over the past several months, the governor has asked me to handle a lot of the day-to-day responsibilities of government while he is focused on the coronavirus pandemic. So we've, as you all know, we've now moved to phase 2 on the Maryland Strong Roadmap to Recovery. Thankfully, we're experiencing a downward trend in the positivity rate with regard to coronavirus, as well as our hospitalizations and ICU beds and other important metrics that are showing that we've, as been probably said very often, we've actually flattened the curve and have been able to do a lot to protect the health of our folks. And so as we continue to try to bring the economy back and open the economy slowly and gradually, we've also been fortunate that we have not experienced the spikes that some other states have experienced with regard to new cases. Our cases continue to climb, and as I said, our hospitalizations are moving in a very positive direction. But this crisis is not over, and all of us and our citizens must continue to exercise physical distancing and take precautions and hygiene precautions, washing our hands frequently and being careful in our public spaces, particularly wearing masks when we're in places where we can't have that physical or social distancing. I like to say physical distancing because we're not antisocial, we're just trying to be physically distant from one another. So as you all know, no one could have predicted this situation that we would then be in several months ago. Just as a side note, the Google, I say the Google, but Google will sometimes send you these messages on your phone if you took pictures a year ago to remind you where you were a year ago. And yesterday happened to be my wife's birthday, along with our deputy chief of staff here. His birthday is the same day, but it showed where we were, not him, but my wife and I, where we were a year ago. And so when we saw those pictures, we thought no one had thought about, a pandemic and being shut down for a period of time. So these are challenging times that we've been going through, and just because the coronavirus has dominated the headlines of late, it doesn't mean that those individuals who have been suffering from substance use disorder or mental health issues are somehow less affected during this time, less affected by their personal challenges during these times. And it's an unfortunate consequence of the physical distancing, the stay-at-home orders, the shutdowns of services that we've seen, not just in Maryland, but across the country, increases in anxiety and depression and other challenges that have exacerbated struggles that individuals have had before this pandemic as they face unemployment or just isolation during this period of time. And I just want to take a side note and mention that there are support groups such as Narcotics Anonymous and Alcoholics Anonymous that are still able to do peer-to-peer group sessions, even in person. The state had always considered those to be essential services, and the fact that we encourage anyone who needed those services, needs those types of meetings to continue to engage. Now, the caveat is that they're still to maintain proper precautions and follow necessary guidelines to minimize the person-to-person contact so that they can keep attendees safe. With that said, there are now more resources available to groups such as those, as well as to the patients receiving mental health services, as well as providers virtually by phone. And during this time, we've been able to, the administration's been able to relax some of the standards associated or regulations associated with telehealth. Legislature passed legislation to assist in that area as well. And I know a number of the comments that came in talked about making sure that we continue the relaxation of telehealth services. And so I just wanted to, talk a little bit about that, just telehealth. And we have talked about this in previous meetings before we had this crisis, that telehealth services are something that can be quite helpful because there are barriers to transportation. It can allow individuals to get access to treatment from distant areas. There are still challenges associated with telehealth. There's things that we're going to need to work on as we go forward, particularly in the area of substance use disorder. Also, we've talked about in previous meetings the challenge associated with if a person moves to a different state and their provider is in a different state, the licensing typically has to be where that patient resides. And I personally think that that's a challenge, that it means that you have to find a new provider to move out of state, or in the event that you're a university student that comes to our state and your provider is, say, your home state is North Carolina, you may have to get another provider here. And that's something that we can look at in terms of how we can address that. I don't know if that can be addressed simply on a state level or it has to be done at the national level as well. Before we go around the go around the internet world, the virtual world, and introduce ourselves, I do want to welcome Delegate Ariel Kelly and Delegate Karen Lewis-Young, as well as Maryland Insurance Administration Commissioner Kathleen Bahrain, to our commission. They're new to the commission. Welcome aboard. We'll give you a moment to introduce yourself, but I want to make sure I just welcome you formally. This is formal, virtual formally, to the commission. Delegate Kelly will serve on the Youth and Family Subcommittee. Delegate Lewis-Young will serve on the Crisis Services Subcommittee. And there's been some leadership changes in terms of the subcommittee. Commissioner Bahrain will co-chair the Finance and Funding Subcommittee, previously chaired by former Maryland Insurance Administrator or Commissioner Al Redner. And then Lynn Lanowski, I didn't butcher your name, and Senator Katie Fry Hester will lead Public Safety and Judicial System Subcommittee. At this point, I'll allow for brief introductions. I don't know where to start. Usually we're at a table and you can say starting left to right, but I see Ms. Lorraine is front and center. Maybe you can start.
Well, thank you very much, Lieutenant Governor. I appreciate your warm welcome. I am extremely pleased to join the commission and to support its extremely important mission, which is one that's dear and near to my own heart. I was a mental health professional once upon a time before I went to law school, and so I'm particularly pleased to be able to hold this role and be on this commission and on the subcommittee. You know, I am new to state government, and I am new to the Insurance Administration. I've been there for 35 days now, but I am excited. My professional career has focused primarily on insurance regulation and financing risk through insurance, and I'm extremely excited about being able to bring perhaps some of that experience and skill sets to this board, to this group. Thank you.
Thank you. Then I'm going to go down the list, and that might make it a little easier. Senator Ecker.
Yes, I am here. Addie Eckert from the Eastern Shore, and it's good to be with everybody again.
Good to see you.
Thank you.
Senator Hester.
Hi, everybody. Senator Katie.
We lost your voice. You said hi, and then we lost you.
Can you hear me now?
Yes.
Okay. Hello, everybody. Senator Katie Hester, representing Carroll and Howard counties, and very delighted to be co-chairing the subcommittee with Dr. Linda Boniaski. Really looking forward to it. And I guess we'll give a little bit of preview of where we're going later on.
Thank you. Thank you. Delegate Kelly.
This took me a second to unmute myself. Forgive my caption that says Brannigan, but it is Delegate Ariana Kelly. Brannigan's my middle name. Couldn't figure out how to change it. Thank you so much for having me. I'm really looking forward to being part of this group. I represent District 16 in Montgomery County, and I have been on the Health and Government Operations Committee. This will be my 11th year, and I chair the network adequacy work group in the legislature, looking at insurance network adequacy, which particularly deals with a lot of behavioral health issues. I also chair the health occupation subcommittee, so those issues that you raised before about licensing go through my committee in the legislature. And I chair the Joint Committee on Children, Youth, and Families, so I'm eager to be part of the Children and Families Subcommittee, and I'm hopeful that I can make a contribution, and thank you for having me. And I'm happy to be joined by all my legislative colleagues. It's an all-star group we have here.
Okay, very good. Well, thank you. Delegate Lewis Young.
Just testing. Can you hear me?
Absolutely.
Great. Well, thank you. I also feel it's an honor and a pleasure to be part of this commission. I truly believe that now and going forward throughout 2021, this will be some of the most challenging and important work that we do, not only for the entire General Assembly and administration and staffing, but in particular for HGO, which I'm a part of. I've been on that group going into my 7th year, and I represent Frederick District 3A. Thanks for joining you, and I look forward to our work.
Thank you. Richard Abbott.
Hi, good afternoon. I'm here. I represent the Maryland Judiciary. I'm Director of Juvenile and Family Services for the Maryland Judiciary. Glad to see that the commission still continues its work and willing to be able to help wherever I can, especially on the criminal justice subcommittee that I've been on since the beginning. Thanks.
Thank you very much. Dennis Schrader. Dennis was on there a few minutes ago. Okay, we'll go to Dr. Jones. Malia Jones.
Hi, good afternoon, and thank you for having this convening as usual. And thank you, Lieutenant Governor, for all of the support that you provide to the behavioral health community. Glad to be with you, Deputy Secretary for the Behavioral Health Administration for the Maryland Department of Health.
Thank you very much. And thank you, Dr.
Lieutenant
Jones.
Governor, I'm back. Sorry about that. All right, very quickly, Dennis Schrader, Chief Operating Officer and Medicaid Director. I've been recently, for the last 120 days, detailed to the governor's office to organize the patient surge process, and have delegated to Tricia Roddy, who many of you may know as the acting Medicaid Director. She's done a terrific job, has been with us for 17 years. So Medicaid's in good hands. But in the meantime, I'll give an update on what the Finance Committee is doing in a subsequent briefing. So thank you, Lieutenant Governor.
Thank you. Major Butler.
Good afternoon, sir. Major Butler, MSP, on behalf of Colonel Jones, the superintendent. Looking forward to continuing the great things that are being done on this committee. Thank you.
Thank you. And Dr. Banowski.
Hi, it's Dr. Linda Banowski. I'm from the Department of Public Safety and Correctional Services, and I look forward to working with Senator Hester as co-chair on this committee.
Great, thank you. Dr. Randy Walters. Randy on. We'll jump to Steve Shue. Director Shue.
Thank you, Lieutenant Governor. Good afternoon, everybody. I'm Steve Shue. I'm Executive Director of the Opioid Operational Command Center and Chair of our Crisis Services Subcommittee.
Christian Mealy.
Good afternoon, everyone. Hey, Lieutenant Governor. Christian Mealy, Deputy Secretary of the Department of Disabilities. Just wanted to quickly announce that for the Youth and Family Subcommittee members on the Zoom call today, we've got our next subcommittee meeting on Monday, the 29th, which we sent out an email about recently. And it is really good to see two of my former HGO colleagues, Delegates Lewis Young and Kelly, on the call today. So look forward to working with you both.
Thank you. Mary Gable.
Yes, I'm here. Thank you, Lieutenant Governor. I'm Mary Gable. I'm an Assistant State Superintendent for Student Services, Enrichment, and Policy at the Maryland State Department of Education. And as we look at our students who have been out of school since March 13th and hope to see them in the fall, and the issues of mental health and other are certainly a priority for us as we bring our children back. So thank you for the opportunity.
Okay. We'll talk a little bit about that as we keep moving on, and particularly when we're talking about youth and families. I've had some conversations with Dr. Salmons with regard to the possibility of even bringing some of our kids back in smaller environments this summer, particularly those who are at risk of falling behind, which would include some of the kids who may have special needs, that bringing them back in smaller groups that can help them from being further behind than typically occurs in the summer months. So we can talk more about that. Barbara, I saw Barbara. Barbara is there. Pat Medashevsky. Pat.
Yeah, I finally found the unmute on this one.
They're all different. It's been a fun time. Anyway, I'm Barbara Allen. I'm the executive director of James Place. We do advocacy and support recovery housing. And I co-chair the Maryland Behavioral Health Advisory Council. So that's what keeps me busy.
Right. Pat Mascot here.
She is on.
Okay. We'll come back. Dr. Rowe, I see you there, but I would butcher your name if I tried to pronounce your name. I see you there.
Sure. Good afternoon, Lieutenant Governor. Hello, everyone. I'm glad and delighted to be joining the group again. Thank you for arranging this virtual meeting under the current pandemic.
Yes, we want to make sure this work continues. Carrie Cho.
Good afternoon, everybody. I'm Carrie Guthrie Cho, and I'm the president and CEO of Cornerstone Montgomery, a behavioral health nonprofit in Montgomery County. I'm glad to see so many delegates and supporters here, and shout out to Delegate Kelly, who's a big supporter. So thanks for having me on this commission. It's been great so far, and I'm looking forward to the work that we still have ahead.
Thank you. Serena Eckwood. I don't know, maybe Serena's not here. And I'll go back to Pat Matuszewski. Pat, did you find the mute buttons? Oh, Pat was there before. Well, in any event, thank you for the introductions. We'll go to the subcommittee status updates, and we can start with crisis services. That's fine. Steve Shue.
Okay, thank you, Lieutenant Governor, and not only for putting this meeting together, but for your leadership on mental health and substance use issues in our state. On behalf of my office, the Opioid Operational Command Center, I'd also like to thank everyone for your interest in this topic and for your participation in the affairs of the Commission to Study Mental and Behavioral Health. Today, I'd like to provide you with a brief update on the activities of the Commission's Crisis Services Subcommittee. Let me begin by saying how delighted we are to have Delegate Karen Lewis Young on our subcommittee. Thank you for joining us. Since we last met in December of 2019, which seems so long ago, the Crisis Services Subcommittee has been prioritizing the development of a comprehensive crisis coordination system. As you're well aware, the coronavirus pandemic has provided a new urgency to our crisis work. We have objective evidence that the pandemic has had a deleterious effect on both the mental health and substance use habits of many Maryland residents. So the work to build a new crisis coordination system is more important now than it has ever been. We envision developing a system that better meets the needs of the state by ensuring all Marylanders have access to crisis services regardless of where they live. We'll be working closely with Dr. Aaliyah Jones and her colleagues at the Maryland Behavioral Health Administration on this effort. We've also been pulling together the various work groups around the state that are focused on crisis services. The OCC convened a coordination call in mid-May to discuss each work group's focus, deliverables, and funding streams. There are at least 5 work groups focusing on crisis services that are up and running here in Maryland. Some of these groups have confirmed funding sources while others do not. We are trying to identify overlaps in these groups' activities in the hope of finding potential efficiencies and consolidation opportunities so that these groups can make the most of available funding. In addition to the Behavioral Health Administration, we are partnering with the Maryland Medicaid Administration to learn more about the role that outpatient mental health centers, or OMHCs, play in serving as crisis centers. This was an issue brought to our attention by Dennis Schrader and has immense potential. The OMHC model has a lot of utility, and it lends itself to accommodating a broader suite of services than many OMHCs offer currently. they tend to be in their more traditional lane of mental health services. We hope to take advantage of the potential in this model and to assist the OMHCs with serving more citizens. Finally, the Crisis Services Subcommittee will host a virtual subcommittee meeting tomorrow, June 24th, from 10 a.m. to 11:30 a.m. We will listen to presentations about strategies for expanding urgent care crisis services and assertive community treatment teams. More detail and login information are available on the Lieutenant Governor's website under the Mental Health Commission tab. Please join us if you are able. Thank you again for your continued attention to these issues and for your collaboration. The OOCC is here to help, so please contact us at help.oocc.maryland.gov if we can be of assistance. Back to you, Lieutenant Governor.
Thank you, Steve. Saw that Teresa Eckwood joined. Ms. Eckwood, you want to introduce yourself real quick? She popped up. Eckwood?
Hello, hi. Yes, I'm with Serena Eckwood. I'm with the National Alliance for Mental Illness. I'm delighted to be here. If ever a time our work is needed, it is now. So thank you, everyone.
Thank you. Okay. Dr. Walters, I don't think is on. Christian, are you able to give an update on youth and families?
Sure, Lieutenant Governor. And I think Dr. Walters, I don't know if she's having connectivity issues, but I think she had compiled our report. But as I alluded to earlier, our next meeting is going to be the 29th. And so far, we've had a really, robust group, very actively participating in our work. And so we've got 17 of our 29 members who have already confirmed that they will be there. On Monday, it's going to be from 1 to 3 o'clock. We are still developing out the agenda. And a lot of what we're doing is sort of a look back on the first round of recommendations. And then in light of the really challenging realities before us, hoping that will inform our work going forward. But hopefully she'll be joining us soon and can deliver the rest of the subcommittee's report.
Okay. All right. I think Pat Manashef, Pat, do you want to introduce yourself?
I'm sorry, I was having a hard time. Did you say Dr. Benesky?
No, it was Matashevsky.
Oh, okay. Sorry.
Okay.
There's Pat.
Hi, Lieutenant Governor. Pat Medashevsky, family advocate with lived experience, and I'm a registered nurse. And thank you for allowing me to be part of this very, very important work.
Thank you again. Okay. Finance and Funding Subcommittee, I guess that's Dennis Schrader. You give an update?
Yes, Lieutenant Governor. So we had spent last year very ambitiously and aggressively organizing a major change initiative around system of care, and we were going to really move that forward this year. Unfortunately, with COVID, we had to reassess what might be the right focus in this interim period while we're trying to get past the COVID crisis, although it's hard to say how long that's going to be. But in the meantime, we decided to do two things. One is because Steve Shue was willing to step forward and provide the leadership needed to drive the crisis services agenda, we pivoted our focus, and particularly because Trish Roddy has so much insight into this from where she sits. And so we've decided that this year's focus is going to be working on the crisis services model and figuring out financially how that might fit in and what some of the options might be. In addition to that, we also decided to stay focused on the behavioral health ASO, Administrative Services Organization. That went live in January. The go live was not satisfactory, so we pulled back and went to a system of estimated payments. So we've been working for about 6 months on that, and now feel more confident that where we need to be, that should be ready to be activated in July. So we're managing that day by day with the advocates. So those two things are where our focus is, and hopefully by the time we get through this year, next year in our third year, we want to reinvigorate the system of care process. But we just felt because there was so much change management required for redesigning the system that we did not want to do that on the fly, because it really requires a lot of careful attention to detail. And we've made so much progress, I did not want to see us have a misstep. So that's where we are. We still have a lot of work going on, but it's not at the scale and scope that we had hoped before COVID hit. So I'll stop there and turn it back to you, Lieutenant Governor.
Okay. When we get to the public comment section, there's a lot of concern about the optimum transition and the estimated payments and where we're going to go on July 1. So, and I think some of our members may have some questions about that as well. But know that I think the majority of the comments that were submitted had to do with the optimum transition and just concern about it. So we can talk about that as we get to some of those comments.
Great, thank you, sir.
Public safety. I guess Senator Hester. Okay.
Yeah. Hi. And Linda Benesky. So Senator Hester and I got to meet for the first time this week, and going forward, we're having a meeting on July 16th at 10 a.m. And we thought to focus on the sequential intercept model that was presented in the annual report. And I just wanted to provide an update on the Department of Public Safety and Correctional Services about what we've been doing. The Secretary has collaborated with the judicial system consistently through the emergency, and the following is being done. We've setting up video connections with courts to conduct judicial proceedings, to limit transporting inmates, detainees to the courthouse. Since the end of April, we have collaborated with the mental health courts in Baltimore City and have conducted a total of 24 virtual psychiatric evaluations. And these are the patients waiting to go to MDH. We've been collaborating with MDH since the beginning of this to set up protocols and testing and for mental health patients that are going to go to their hospitals and for them returning to us. So, and it's been going really well. We meet with them weekly. So that's what the update is for the Department for Public Safety. And next time we all meet, Senator Hester and I will have had a subcommittee meeting. Senator Hester?
Yeah, thank you. I just wanted to quickly add on and thank, Dr. Nero, if he's listening, for his incredible work last year. Really looking forward to co-chairing this committee. And just for those of you who aren't familiar with the sequential, intercept model, it basically looks at the 6 intercepts over the course of a.
Wait a minute, we just lost your audio. We just lost the audio for you. I was going to ask about the sequential intercept model. You were just starting.
That's correct. We, from the last meetings last year, I'm sorry, Senator Hester, your face. So we decided that that was going to be our focus. That was one of the recommendations. And so hopefully when we get together with the committee, we will devise our more recommendations regarding this model.
Now, let me, and I'm going to, I think, probably Senator Hester was going to explain this, but it's these 6 steps. And as I understand, the first place that you can intercept is at community services. And
Correct.
then the second, hopefully you don't get to the second, but the second would be in law enforcement, where law enforcement is called in for, certain situations. Then initial detention and the detention and the initial court hearing is the third. Jails and the courts being the fourth. Re-entry, and then community corrections would be the last.
That's correct.
Right.
Thank you, sir, for explaining it.
I don't know if I explained it, but it seems like those 6 steps with different titles or different places where you intercept can be done not just in the criminal justice side of it, but in other places where, of course, it all starts with community services, and then other places where there are engagements. And even if we look at it from the law enforcement or the first responder side, the second step can be either law enforcement or a first responder, like EMT. Sometimes families will call, an EMT to come and intervene in a crisis situation where they think it's really a physical issue, but really it's more of a psychological or mental breakdown that's going on. And so that could be the intercept in the non-law enforcement side. Senator Hester, are you audio now? No, maybe you should sign off and sign on. Oh, did you just do that?
She went camera on.
Yeah, she did camera off. Okay. So I'm just thinking broadly that this sequential intercept can probably be done not just in the criminal justice realm, but in the social services realm as well, and health services as well. But I don't know if anyone else wants to make a comment, particularly our public members.
I'm back. Can you hear me now?
Yes.
Sorry, I have no idea what happened. You guys covered the sequential intercept model really, really well. So thank you so much. I think the only things I wanted to add was just, a personal thank you to Dr. Nero, who chaired this subcommittee last year. He did an amazing job, and I learned a lot from him. And certainly he will be missed, but you guys are all in good hands. I think the other thing that can be said about the sequential intercept model is we had a really good conversation with Steve Hsu and his colleagues. There's definitely overlap, as you were saying, between the crisis intervention team and the public safety and criminal justice team. So we'll be working closely together. And the model can be used as, both to ask the questions, what does Maryland
You got rocky and then you froze on us. Oh, it's gone again. Is Carrie Joe still there? Carrie?
Yes, I'm still here.
Do you have any feedback with regard to this talking about the sequential intercept? How you see that?
My dog is trying to comment, but I have heard that I have seen Montgomery County actually explored implementing it for not just criminal justice, but also social service issues. So it is something that I understand it can be used across many domains. It's not just for criminal justice or corrections. So I think it is a very useful tool from what I remember when we were looking at it in Montgomery County.
Lieutenant Governor, this is Addie Eckert. Yes, most of our jurisdictions on the Eastern Shore have used that over the years, and it is a very helpful model. I know we've used it not only through our local behavioral health authorities, but I think also with our CJS groups as well. So yes, it's a very helpful tool.
When you said CGS,
Criminal justice groups that meet. Many of our communities have all the stakeholders at the table. I think Steve Shu's been around to a number of those, so he appreciates the good work that they do.
thank you. Oh, and I was reading about it, I thought it was something that could apply in many realms.
Correct.
Good. Okay. Any other comments from our members? Okay. Hearing none right now. I think Senator Hester came back. Senator, are you back?
I'm back and I'm calling in from my cell phone now.
Okay. You blanked out just when you said there was one more thing you wanted to add about the sequential intercept model.
Did you hear the part where I was just talking about how it overlapped with the work that the crisis services team was doing?
Yeah.
Okay. And then, I mean, I kind of see it as an excellent framework to look across the intercept and ask, what does Maryland currently have in terms of our resources at each of these things? Because there's a lot of good stuff going on.
Right.
And the second question is, what are our greatest needs? And the third question is, then how do we meet those needs? So it's a really good tool for a gap analysis. And I think it will overlap with what the other committees are doing. So I'm looking forward to collaborating with you all.
Okay. Thank you. Thank you. And that came in loud and clear. So if there are no other comments from the commission members, we'll move on to a special presentation from Ariel Judah, who's the Deputy Director of the the Governor's Federal Relations Office, to talk about the CARES Act and federal resources that hopefully are coming our way. Is Ariel there?
Yes, thank you. Can everyone hear me?
Yes.
All right, let me try to screen share so everyone can see this presentation. Let me see. Oh, it's not getting. Just give me 1 second.
Okay.
Okay. All right, is that working for everyone? Sorry about the delay.
We see it here.
Okay, excellent. Well, the hot topic of the moment in Congress is, of course, coronavirus relief. So I'm going to give a quick overview of the CARES Act and other federal COVID-19 resources that will be available to the state. Here's some background on the CARES Act. It's a $2 trillion bill considered to be phase 3 of the coronavirus relief packages, and it was signed into law by the president on March 27th. Some of the highlights of the bill include the Coronavirus Relief Fund that gave $150 billion in aid to states, territories, municipalities, and tribal governments. Maryland got a total of $2.3 billion in assistance. Some other key parts of the bill included the Paycheck Protection Program for small business relief, enhanced unemployment insurance, plussing up weekly benefits by $600, providing 13 weeks of extended benefits, and then also created the individual one-time cash payments. The CARES Act provided resources for services and supports that benefit people with mental health conditions and substance abuse disorders. It provided $425 million for the Substance Abuse and Mental Health Services Administration. We're tracking the grant funding for Maryland. So far, none of these grants have been awarded to Maryland entities, but we'll keep you posted on MDH's efforts to apply for this funding. The bill also provided $17.4 billion for HUD, including $4 billion for homeless assistance grants to address coronavirus among people experiencing homelessness and to help individuals and families who are at risk of homelessness due to coronavirus. It also had $5 billion for the Community Development Block Grant Program. The bill included $19.6 billion for the Department of Veterans Affairs, with a focus on expanding mental health services through telehealth for case managers and homeless veterans that are part of the HUD supportive housing program. $14.4 billion to support increased VA services, including programs to assist homeless and other vulnerable veterans. And something that would be of interest to this group, of course, patient confidentiality changes in the bill. The CARES Act modifies the 42 CFR Part 2 regulation governing substance use disorder records to allow for sharing health information among providers with initial written patient consent. So now, from the time that the bill was signed into law, HHS has 12 months to work with the appropriate federal agencies to make revisions to CFR Part 2. So it remains to be seen how expansive the scope of allowed redisclosures will be, but we'll keep you posted on that.
Can I interrupt you for a moment?
Sure.
So what that does is allows for the sharing of the information with providers, but it's still subject to the patient's consent.
Yes. So if they consent one time, then the information can be shared from there. But we're still waiting on exactly how this is going to be implemented since HHS is going to be making the revisions.
Because one of the challenges that is out there is that a person who may be getting treatment for substance use disorder, and let's say the treatment includes methadone, they go into a doctor's office because they blew out their knee, doing something, playing basketball or something that they're too old to be doing. And the doctor wants to prescribe them an opioid. If they don't tell the doctor, the way current law has been, if they don't tell the doctor that they are currently getting treatment for substance use disorder, they can be prescribed that opioid. The doctor, their primary care physician does not have access to that information because of the restrictions in the CFR. And so while getting patient consent is great, it's still kind of, if they, hopefully the written consent, they won't feel as ashamed to tell their primary care physician that they are on methadone, or even if they're not on methadone, that they're, in recovery of some phase, that if you're just offered that, opioid, it may throw you back. So that's the concern I have. And it goes the other way too, where the person may be, going into their primary care physician because they're having difficulty sleeping, but they didn't tell their primary care physician that they suffer from depression, and they're getting counseling, and they may be prescribed Ambien or something that can create problems for a person who already is suffering from some mental health issues. So that's the concern I have, because the federal government has set up these barriers because they look at so many things in isolation, but they don't understand that the crossover, that your primary care physician is precluded from seeing these other places where you're getting services. So I know they tried to address that a number of years ago with, I forgot the legislation that was, what was the legislation that a couple of years ago? You guys are all new, so I don't know. There was legislation that was done that addressed mostly substance use disorder, Terry Cho, remember, that was done maybe 3 years ago.
Yeah, it was. I forget what it was called as well, but it really, most people don't feel it went far enough.
Right.
Yeah.
Yeah, it had a provision in there to try to address this issue, but they left it to, I think, the bureaucracy at HHS to try to deal with it, and they really never did.
Yeah. Yep. Unfortunately.
CARES Act is all on my mind now, but it was something like that, and it dealt primarily with substance use disorder, but it did address some of these other problems with the mental health side.
I believe it was the Support for Patients and Communities Act in 2018.
Maybe.
That's what, yeah.
That sounds familiar.
What was the acronym, or what was it called? I'm trying to remember. It may have been before then, because I think it was Obama. I think it was Obama era legislation.
Yeah, I think you're right.
Yeah, it was Obama era legislation, right around the end of his term. So, okay, up to me when we get off the line. So, okay, sorry to interrupt, but I just wanted to point that out that's still a change. Hopefully, this helps a little bit. I don't know if it helps enough, but let's see.
And I'll make sure that we know if there's opportunities for Maryland to weigh in as HHS revises the regulation, then, we'll be able to do that.
Sure, yeah, because I think we need to let these folks know. I don't think that enough people realize the challenge. I testified before one of the subcommittees many years ago when the congressman from Pennsylvania was the subcommittee chair, and he dealt with a lot of, he resigned real quick because he had some ethical issues, but he was really a champion on mental health issues. And I mentioned this issue in terms of this barrier between substance use disorder treatment and as well as mental health treatment, and that your primary care physician does not have access to that information. If you trust your doctor, or if we as a society trust the doctor, and I know there's a privacy question, and I know we want to protect against the stigma, but that's just something we have to grapple with. And maybe this is the solution. Okay, thank you. Continue.
Thanks. So I wanted to go over Maryland's use of CARES Act funding for mental health services so far. Now, some of this is still kind of up in the air as we apply to the different grant programs as they're rolled out by HHS. But we've used $420,000 in the federal relief funding for the Maryland Institute for Emergency Medical Services Systems effort, for mental health supports, for personnel working at nursing homes and long-term care facilities. Oops. Let's see. The next program that I wanted to go over and make sure everyone was aware of is the FEMA Crisis Counseling Assistance and Training Program. On March 26th, President Trump granted a major disaster declaration for the state of Maryland, and that triggered the release of federal funding to help our communities recover from COVID-19. Our state was approved for the Crisis Counseling Assistance and Training Program, which helps individuals and communities recover from the psychological effects of disasters through community-based outreach and educational services. This funding is going to enable Maryland to expand upon our existing behavioral health resources, such as call centers or telehealth, so we can handle the increased need for services in communities due to the pandemic. The Maryland Department of Health Behavioral Health Administration received a $90,000 grant from the FEMA Crisis Counseling Immediate Services Program, and they're going to use this funding for a marketing campaign with Maryland Public Television to address counseling needs of providers in nursing facilities. There are two other behavioral health projects currently being funded with COVID-19 federal aid. $211,000 for enhancement of the behavioral health resources database at 211 Maryland, as well as $125,000 for the creation and distribution of behavioral health PSAs related to coping and mental health. We also have a couple future health projects in the works. BHA is working on an application for a FEMA crisis counseling regular services program grant. That's different than the immediate program grant because it would provide funds for up to 9 months following the disaster declaration. So it's more long-term. BHA is also in discussions with Behavioral Health Systems Baltimore regarding a request to strengthen telehealth resources of the behavioral health providers in Baltimore City. And finally, BHA could look to strengthen statewide behavioral telehealth needs pending the federal funding that we receive. I also wanted to bring to everyone's attention the resources from the White House Office of National Drug Control Policy. ONDCP is currently leading efforts to ensure that prevention, treatment, recovery support services, and safe and effective pain management remain available during the COVID-19 pandemic. They've released a really helpful fact sheet that has information about federal actions taken to expand telemedicine, e-prescribing, and other issues. So I've included a link to that in the PowerPoint. I don't think you can click on it with my screen share, but everyone has a copy of this. So that's a very helpful fact sheet. Please feel free to distribute amongst your networks. And tomorrow at 3 p.m., there's actually going to be a launch of the Rural Community Toolbox website, which is a new resource for rural communities impacted by addiction. So wanted to flag that for all of you. I also included a link to the registration if you want to participate in that call or have somebody from your team participate in that call. The Toolbox is going to serve as a clearinghouse for funding and resources in over a dozen different federal agencies to help rural leaders build strong, healthy, and drug-free communities. I've included some more COVID-19 mental health and behavioral health resources that we've received from the federal government, including from SAMHSA and from the Department of Veterans Affairs. And I wanted to make sure everyone had the disaster distress helpline information, which provides 24/7, 365-day-a-year crisis counseling and support for people seeking help in coping with mental or emotional effects caused by the coronavirus pandemic. And finally, I just want to go over the next steps at the federal level. As chair of the National Governors Association, and he's chair until, I think, for another 4 or 5 weeks. Governor Cuomo will take over in August. But as chair, Governor Hogan has been leading the effort to secure additional COVID-19 state stabilization funding from the federal government. Governors are urging Congress to provide at least $500 billion in direct financial assistance to states so they can address the budgetary shortfalls that the pandemic has created and will create. We're hopeful that we're going to see a phase 4 supplemental relief package sometime in July. And that could include additional state stabilization funding, more support for behavioral and mental health services. That's one of the things we're starting to see everyone start lobbying for to be included in the package, as well as a second round of those individual stimulus checks. This is probably going to be the last piece of really meaningful legislation passed before November. So stay tuned and we'll keep you posted from the governor's DC office. And there's my contact information if you have any additional questions on anything involving COVID-19. It's pretty much all we're focused on right now.
Well, thank you. And what I was trying to remember is the CARA Act of 2015.
I just Googled it. I just Googled it as well.
CARES and CARA kind of ran together, but in 2015, so we were right at the timing that it was about an era, but it was supposed to address some of these issues in terms of that communication, addressing HIPAA, and how families can get information about the treatment of their adult family members, because as we've talked about before, that child of yours gets 18 and all of a sudden the door shuts down in terms of what information you can get. And many times the doctors don't quite understand HIPAA and they just feel they can't talk to you at all. versus they really can't talk about the diagnosis and treatment and things of that nature. But, you know, so that was, yeah, sometimes they work on it, but because there are elements in that in the CARA Act that we're supposed to start addressing these challenges, but it hasn't. So hopefully they'll get it right this time. We'll have to see. Not yet there in the CARES Act, but maybe somewhere along the line they'll adjust it. All right, any questions for Ariel?
I just had a comment, if I might, about the CARES Act. That one thing, it's just kind of interesting to note, and I think this happens when there's a lot of money out there and figuring out where it should go. But there are a lot of resources out there, but very little of that CARES money has gone or been directed to Medicaid behavioral health providers. So that's been unfortunate for many of those providers providing services. As we know, there's just going to be a bigger need going forward. So it's just been an interesting outcome that's resulted so far.
Yeah. Is that something, Ariel, we can direct to our legislative team, our congressional organization?
Absolutely. So we have the governors weighing in very frequently on what they want to see in the next phase 4 relief bill. Medicaid behavioral health has been one of the key things in the discussion. So we'll make sure to keep pushing for that.
Thank you.
Senator Eckert here. I have another question. And that has to do with, I know once we're out of the emergency declaration, we're not going to be able to have the benefit of using phones as well as telehealth to reach many of our clients. And that has just made such a difference in being able to get patient engagement, client engagement with regard to crisis intervention and treatment. So we really need to be paying attention to whether or not Medicaid and Medicare are going to reimburse following the crisis for those telehealth and specifically phone consultations and interventions.
Now, I believe that CMS released some guidance that they were going to allow the audio only telehealth consultations, but I'm going to track that down and I'll follow up with you.
Please, thank you, because that's the biggest outcry I'm hearing from all of our providers on the shore.
I think statewide we're hearing that. And I know with the legislation that was passed in Maryland, it still left it up to, I think, our Medicaid or Department of Health.
That's right.
To seek a waiver so that they could continue to do this. And I know Dennis is on the line. I don't know if anything has happened on the health side, requesting a waiver with regard to Medicaid to be able to continue to do this beyond the emergency.
That's the question.
Yeah, we're not sure yet, Lieutenant Governor, but obviously telehealth has been pushed quite a bit on a number of fronts, and we'll be monitoring that ourselves because the other question is, will the industry be analyzing the efficacy of this? Because it's one thing to do it, it's another thing to prove that it's had impact on the outcomes. And so we're going to be looking for that kind of data to support that. But so we've moved way past piloting to implementation, and that'll be one of the questions, I'm sure, as we go forward.
Right, but I think the legislation that was passed was talking about, a waiver to pilot the idea so that you could collect that data. Because some of the comments that we've received from some of the providers, that they're finding that they're able to at least get in contact with many more of their clients, as well as, and this kind of goes to a little bit of the privacy side, they get a view of the environment that their client is in as well. Now, cringe a little bit on it, but also there's a little bit of being able to see where that client is. So perhaps piloting, we can get some data that can support the continuation of that type of service, but it does shut down one barrier or address one barrier, which can often be transportation, to get to that provider, where, you know, either bus service if they're in a suburban, urban area, or, you know, if you're in a rural area where transportation can be more challenging, or in a distant suburb, it eliminates that particular barrier, and in some cases, excuse for not seeing your
Yes.
therapist.
Yeah.
And I know
Yeah,
it's
and their excuses. You know?
Yes.
So,
Yes, for sure.
And then there are some clients who have just blossomed, being able to be at home on their own schedule and having control, much more control over their environment, who've done extremely well, that usually, if they're in a group situation, get a lot of anxiety. So yeah, you're exactly right. We need to have the specific outcomes, the behavioral changes that we're seeing well documented, so that we can make a case for this going forward.
Thankfully, there is research that shows that it does have efficacy, but and I will also freely say it doesn't work for everyone. Not everyone responds as well. I mean, that's why it's so important, I think, to add it to the continuum, because you're right. Some people have just blossomed with this treatment. I will say, to the amazement of providers, therapists and prescribers alike have been very pleasantly surprised by how it's been so well received by some clients, but realizing it's not for everyone, and we're going to have a continuum of options, which is, I think, only makes the system better.
Correct.
I think, Carrie, we've had a conversation with regard to like children. Sometimes it doesn't work as well with children, keeping them focused on a screen versus being able to see the person, directly and keeping them.
And there's just some clients who get paranoid by being on a computer or on a phone. They don't trust it. They'd rather be face to face. So there are definitely people it's not appropriate for.
Okay, and it's not just the politicians who are paranoid being on the phone. Right? Okay. All right, sorry. Sorry, for the new delegates who just came on, I make those kind of comments from time to time. Nothing personal. Okay, we have public testimony. I think everybody was sent copies of the public testimony that was submitted. Unfortunately, typically, and particularly for Delegate Kelly and Lewis and Commissioner Barang, we have public meetings and people sign up and they speak, they talk about their challenges. Oh, thank you, Ariel. I forgot to thank you for your presentation. But because we're doing this virtually, we aren't able to, at this time, take live public testimony. So we ask individuals to submit their testimony in writing. Individuals can still submit testimony. Some of those who submitted testimony, or anyone who's watching, if they want to submit testimony, they can. They can still do that. If they submit it by tomorrow at 4 o'clock, it will be posted on our website, which I will give later, but just quickly, it's ltgovernor.maryland.gov/MBH Mary Boy Henry Commission, that's it. ltgovernor.maryland.gov/MBH Commission. They can still submit comments. So Hannah Marr, who's here with me, is going to read, summaries of those comments.
Thank you, Governor. So, as the Lieutenant Governor mentioned, we did put out on our website for organizations and members of the public to submit written testimony. We got 18 submissions, which is pretty much more than we expected, more than we got for our last session meeting. This is able to throw in and QA council. We got some from private citizens as well as advocacy organizations, on a wide range of topics related to mental health. We received submissions from following organizations: the National Alliance on Mental Illness, NAMI Maryland, the Maryland Clinical Social Work Coalition, and the Greater Washington Society for Clinical Social Work, the Maryland DC Society of Addiction Medicine, a chapter of the American Society of Addiction Medicine, Sanmar Family and Community Services, On Our Own of Maryland, the Legal Action Center, the Maryland Coalition of Families, the Baltimore Harm Reduction Coalition, a program of Fusion Partnerships, Inc., Chesapeake Voyagers, Inc., Wellness and Recovery Center, the Children's Behavioral Health Coalition, Catholic Charities, Shepherd Pratt, the National Council on Alcoholism and Drug Dependence, Maryland Chapter, the Community Behavioral Health Association of Maryland, the Mental Health Association of Maryland, Leading by Example, and the Carroll County Youth Service Bureau, Inc. So as the Lieutenant Governor mentioned, just in the interest of time, we're going to be summarizing the submissions, and we did our best to group them based on topic, but they will all be available on our website following the meeting. And many of the organizations that submitted comment submitted it on more than one topic. So you can go to our website that LG mentioned. It's ltgovernor.maryland.gov/MBH Commission, and you can learn more and see what specific topics the organizations submitted their testimony about. So the first topic is on the 4% increase in the fiscal year 2021 budget for behavioral health services. We received 8 submissions on this in support of meeting budgeted 4% increase, which is planned to take effect on July 1st, 2020. The consensus among all the submissions was that behavioral health services have been chronically underfunded for many years, predating the current administration, and that this 4% increase in funding is vital in order for providers to continue their support services. And without the funding, the organizations that are already strained financially will have even more difficulty providing these much needed services. The second topic is on the Administrative Services Organization transition to Optum, which I know was mentioned earlier. We received 3 submissions from this, all of which detailed the inadequacies of the Optum system, and it was clear that many providers are all experiencing the same issues. Multiple submissions explained how the system has continually failed on basic functionality measures, and in addition, multiple submissions detailed how Optum's authorization and claims payment system continues to fail, and how that transition and failure has been financially destabilizing for providers who are receiving estimated payments based on 2019 data that's not sufficient to meet their current financial needs. So we can see that that's clearly a problem, and all 3 of the submissions that were given said very similar things. Next, we received 5 submissions in support for continuing and expanding telehealth options for providers even after the COVID-19 crisis and state of emergency is over. And that's obviously something that this commission has been talking about for a very long time. The general consensus is that the ability to engage in telehealth services has been a net benefit for providers to maintain the continuity of care, and in some cases to reach more Marylanders who otherwise may not have received the care that they needed. Additionally, a common theme among all of the submissions was that telehealth prevents people from falling through the cracks. And there was a consensus among the submissions that we received that telehealth should be expanded to allow for access for those who do not have readily available access to smartphones or internet, by including audio-only teletherapy. And additionally, there were some calls for all insurance companies practicing in Maryland to reimburse providers for telehealth services at the same rate as in-person services. And there was some more on telehealth as it relates to youth and families, which we'll get to in a few moments. Regarding the sequential intercept model that we talked about earlier, we did receive 1 submission urging the state to implement the model, and they had mentioned the recommendations by the Justice Subcommittee. And they said that it was a critically important strategic planning tool to identify and assess available resources and identify gaps in service that need to be addressed. And the model would map points at which community services and other interventions intersect with individuals with behavioral health issues across the state, and would enable the transformation of local and state systems, jail diversion policy, and the documentation and promotion of evidence-based and best practices in program development. The model focuses on 6 distinct intercept points: community services, law enforcement, initial detention and initial court hearings, jails and courts, reentry, and community corrections. And these are all used to identify gaps, resources, and opportunities at each intercept for adults with mental health and substance use disorders. From here, statistical and evidence-based priorities can be designed to improve the system and service of response. The committee also received one submission in support of HB 1300, also known as the Kerwin Bill, or the Blueprint for Maryland's Future. The submission calls on this commission to put forward a plan to fill the school behavioral health gaps left by the veto of this bill. And it details that the bill included a comprehensive set of strategies for enhancing school-based behavioral health services, dedicated staff at the Maryland Department of Education to coordinate with school behavioral health services coordinators, requiring training of school personnel in all schools to recognize student behavioral health concerns and protocols to support students in need of behavioral health services, require each local school system to develop and implement systematic screening to identify students with behavioral health needs, and established a Maryland consortium on coordinated community supports to develop and fund community partnered school behavioral health programs across the state. And we also received one submission that Maryland must do more to ensure compliance with the 2008 Mental Health Parity and Addiction Equity Act, or Parity Act, so that private insurers and Medicaid meet their legal obligation to cover mental health and substance use disorder benefits at the same level as medical services and allow Marylanders to access the care that they're entitled to receive. It details that although Maryland Medicaid has convened a parity discussion group as part of the system of care redesign work, it has not set out a process for resolving existing violations regarding prior authorization standards, reimbursement rate setting practices, and benefit coverage. In addition, the submission states that the state sought and obtained Centers for Medicare and Medicaid Services approval to remove prior authorization requirements for many medical services through a Section 1135 waiver, but did not include mental health and substance use disorder services in its waiver request. Also, under HB 455 and SB 334, state regulated insurance carriers would be required to submit compliance reports in 2022 and 2024 to demonstrate Parity Act compliance. However, carriers will not be required to demonstrate parity compliance for 2 plan features that have the greatest impact on access to care: reimbursement rate setting and network adequacy. The Maryland Insurance Administration has issued 11 orders since 2015 finding state and or federal violations of network standards for mental health and substance use disorder providers, and the submission urges the Commission to require the MIA to require parity compliance reporting on network adequacy and reimbursement rate setting, and to take action to ensure that carriers charge members no more than the in-network rate for mental health and substance use services that they approve for delivery from a non-participating provider because of an inadequate network. And finally, as I mentioned, in addition to the issues discussed previously, nearly all of the 18 submissions we received included, at least in part, information regarding the impact of COVID-19 on both mental health services and on the individuals themselves who are dealing with mental health challenges. In particular, youth and families and as it relates to substance use disorder and substance use overdoses. While the overwhelming reaction to the state's efforts to expand telehealth opportunities has been positive, we did receive information regarding challenges in telehealth services since COVID-19 began that should be addressed. In regard to children and families, this includes a lack of access to technology and internet, a lack of privacy for youth to speak freely with their providers, and difficulty in engaging youth through telehealth, leading to abbreviated sessions or the discontinuation of telehealth services altogether. And this has posed challenges with relation to distance learning for children with mental health issues who have been receiving special education services. In some cases, behavioral problems, inability to focus or stay on task, or occasional outbursts can pose insurmountable challenges for students, making distance learning nearly impossible. And regarding substance use disorders, an increase of overdoses and overdose deaths has been reported. Additionally, a common theme is that virtual meetings are not always adequate for some people in recovery and cannot replace face-to-face interactions or peer support services for those. And finally, we received submission in support of the following. Increasing funding to harm reduction programs and officially declaring such services as essential life-saving public health programs, decriminalizing the possession and distribution of drug paraphernalia for personal use, and establishing overdose prevention sites. Again, this is just a brief summation of the submissions that we received, and anyone who is interested in learning more can see the submissions in full on our website following this meeting, and they will be at ltgovernor.maryland.gov/MPH Commission. You'll find all the links to get you that information on it.
And Ms. Perrine, I would just, the parity question has come up a lot in terms of how private insurance responds to folks with mental health challenges and network adequacy. I think it's been an ongoing challenge that families are not able to, there may not be a provider that's in their insurance network. And so they run into these challenges, and in worst case scenarios where the insurance just doesn't cover the situation that they have, they either have to pay out of pocket or the child has to become independent so they can qualify for Medicaid. And so that's a challenge that, we've been trying to grapple with for a while in terms of how we can, make sure that the private carriers are willing to pick up the expense associated with covering these kids, where the state/federal plan, Medicaid does do it, but the private insurance doesn't, and that is a particular challenge.
Thank you. It is absolutely a challenge, and it is an issue, and I think that's part of the importance of the survey work and the access work that we've been asked to do, including the most recent legislation by the legislature, to really examine the issue and see what's actually happening in the marketplace now.
Any questions about, typically when we have the public comments, it's a person gets up and speaks and we can interact with that person. So I know that was a summary of all these. If anyone's had a chance to read the comments that was submitted, or any comment to the comments, response to the comments. Senator Hester.
Yes, thank you for the summary. I thought it was incredibly helpful. And I just wanted to offer, I actually worked on drafting that legislation that was part of the Kerwin, the Blueprint for Maryland, that dealt with the community support partnership. It was a bipartisan group of like 4 or 5 senators who wrote that piece. And it's really good. And during the process, we found a way to leverage about $75 million of federal Medicaid funding that we could get to the kids through the school system. And so while that legislation is currently vetoed, if anybody wants to talk with me about this offline, I'd be happy to try to connect the dots for you. It was that part made it in at the very end, so it didn't get much publicity or much attention, but it's a really fantastic piece of legislation, if I do say so myself.
Well, sometimes things that work can be taking things out in pieces, because I think generally there was a lot of agreement on that section. And so sometimes, as they say, to eat the elephant, it's one bite at a time versus, something that is so overwhelming, and particularly in the financial situation the state is in right now. So that may be something. The other senator from Eastern Shore, Addie Eckert.
Thank you very much. I would agree. I was just texting one of the other members on the commission that, one of the best things I think we could do out of Kerwin was that behavioral health and community support program that we all work so diligently on. Just because I think now more than ever with the whole COVID experience, the need is there. And many of our school systems are already beginning to see that and address a number of those issues over this summer. And if there would be some way we could take a look at that and figure out how we could modify it or stage it, phase it in, or to get buy-in, I just think it would be such a wise investment on our dollars going forward. So I would just support Senator Hester's comments on that.
I don't know that the federal CARES Act, I know that there's discussion of addressing some of the Medicaid aspects, and there is CARES Act funding that goes towards broadband use in schools. I don't know if there's anything that we can be creative on this next phase, if there is that next phase of CARES Act funding, that there may be something that can help in that particular area. Mental health generally, something that addresses children in schools that are impacted. Maybe at least some funding.
We found in the rural areas, Lieutenant Governor, that many of our school systems have not been able to reach some of the students because of lack of the hardware, the physical presence of a laptop in the home and being connected. Even the hotspots are limited in some of our areas. And then the other issue is the ongoing cost. So students lack accessibility based on the equipment and the connection, and then the cost. So anyway, we've been thinking about it on the Eastern Shore to look at how we roll out a well-coordinated network and continue to push out that We Connect Maryland because of all the changes that will result as the COVID experience. So you're exactly right.
Yeah, like I said, I know that there's some broadband support that's coming down the pipe, but also, and this is something that maybe, if it's not statewide, I mentioned it to Superintendent Salmons a number of weeks ago, probably months ago now, that in a conversation that we had with the national lieutenant governors, what Texas was able to do. Now, Texas, of course, is a huge state, 29 million people compared to our measly 6.1 million people. But they were able to negotiate a statewide contract with, I believe they said it was with Apple Computer, to lease Apple computers or somebody's laptop for $99 a year for these computers, which their individual school systems actually paid for them, because they looked at it that at $99 for the computers, it was equivalent to a book or two books that the school system was buying. And what they required required was that the family, $10 a year, insurance wanted to do. And if the family couldn't afford the $10, that they had some assistance for them. Now, again, they're a huge state that can use that leverage to be able to get some that kind of support. But maybe regionally, I know some of the jurisdictions have already negotiated deals, computers, I know Baltimore City did something, but maybe the shore counties can, collectively try to negotiate with some of the equipment providers and see what can be done there to help. And then with the federal money coming in, maybe it would be something. And it could be other shore counties along with any other counties that want to come in and apply. Just something to think about. I'll talk to Dr. Salmon again to,
Yeah, I think
about that.
Thank you. I think we have the laptops, and everybody's made an effort for that. It's the connectivity on an ongoing basis. That
right. That's,
yeah.
Getting that last mile.
The last mile, the middle mile, correct.
Yeah.
And that challenge with broadband access is the same problem on the telehealth side that their parents are experiencing. And
right.
So the families, the one complaint that we had, VHA just did a survey of our provider community around the telehealth experience and how behavioral health patients have changed their behaviors to access behavioral health services during this time. And the one constructive criticism or complaint that patients and providers had was around connectivity issues. That was the only thing that they really complained about.
Mm-hmm.
Any other comments?
I was going to ask.
Dr. Jones.
Hi, I'm still here.
Hi, Dr. Jones. I may have missed some of what you said. I've been kicked off a couple of times, and I'm calling by phone now. Is there any information on how we're doing with the hearing impaired and the senior population in being able to utilize the telehealth or not?
That's a really good question. So with senior population, the survey that we did was for all populations from childhood to elderly, and we had almost an equal representative proportion of providers responding. So lots of providers who also worked with elderly populations as well as with youth and middle-aged and young adult. And there was no difference in performance. Again, it goes back to that telehealth isn't for everyone. However, it should be a modality that's available to add to our armamentarium of modalities available for the continued treatment of behavioral health conditions moving forward. But the elderly population did not separate out in terms of their experience with telehealth any more than any others. That's not really what stood out. And with regards to the hearing impaired, I honestly can't say that I've parsed that part out. We didn't look specifically for information for the hearing impaired. We have provided guidance about telehealth for the hearing impaired, but we haven't done specific or asked for specific feedback for that population. But we can certainly do. Our plan is to repeat the survey or a survey in August, and so we can certainly look at that then.
So how are the seniors being accommodated now? I mean, are they being able to see someone in person, or are they just not getting the services?
Most patients, so people who are not receiving services, it hasn't largely been because there are no providers available. We have good availability for providers. When we surveyed probably 2 months ago, about 85% of our providers had moved over to telehealth, but most of our providers did not 100% shut down their operations. That was one of our another survey that we just did through our local behavioral health authorities. So we didn't have any jurisdictions that stood out as not having services available, whether it was telehealth or walk-in. I think that it probably, so from that perspective, again, I don't have any data, and I haven't heard any reports from the community that has said that what they have done for the elderly population has been any different than what they've done for everyone else. And some of it has been about patient preference. Some patients did not want to move over to the telehealth modality, and so they continued to be seen face to face. And then other patients were very, very uncomfortable with the thought of having to leave their home during this pandemic. And so they use the telehealth platforms. So, but I haven't heard any specific reports about specific challenges for the elderly population that were different than anyone else's.
Are you hearing that we are utilizing the ACT teams more now?
Utilizing them, well, so the assertive community treatment teams, well, there's not really using more. So there are a certain number of teams, and they have a catchment of patients. And so the ACT teams have not specifically grown during this time. It would be not to my knowledge, and I can't think of any reason why they would have grown during this time, particularly because hospitalizations were down during this time, and that's a big way for people to be referred to assertive community treatment teams. And the assertive community treatment teams have used more telehealth. They typically and traditionally didn't use telehealth modalities prior to now, but we gave them the flexibility of being able to do that so that they could keep themselves and keep their patients safe. And some probably use social distancing, but also use telehealth as well to ensure that they were able to continue to meet the need there. I think that the way that we look at effectiveness from that perspective is we look at emergency department utilization and hospitalizations, and we did not see an increase in psychiatric emergency room utilization and or hospitalizations per the conversations that I had, at least with the Central Maryland region hospitals about 6 or 7 weeks ago now.
I could speak to just Cornerstone Montgomery for all of this. Everything that Dr. Jones said is exactly what we've experienced, that the older patients, the only difference might be more of them are doing phone only services, but that would be the only difference. Many of them are still accessing telehealth or coming in if that's the option they want. And as for ACT, we aren't seeing more clients. We're still doing intakes. We're still open, but our ACT team is out in the community. They're considered essential, just like our residential services. They're out seeing clients, using the PPE and practicing the physical distancing. And they are using more telehealth than they were, but they're still, our ACT teams anyway, are still seeing people more face-to-face than telehealth, although they are using more telehealth than they were before. So everything Dr. Jones said is exactly what we've been seeing at Cornerstone Montgomery.
Thank you.
Thank you. Thanks to both of you.
Thank you. Okay. Well, as we're wrapping up, unless there are any additional comments or concerns that anybody has want to mention.
I'd just like to say to all the members of the committee, Dr. Jones, you've done a terrific job. Your website's great, the resources that you all have been cranking out on a regular basis. So I just want to say kudos to everybody who's been working from the department, Lieutenant Governor on down to Dennis Schrader and Webster, the whole department, and Steve Shue have just been so well organized from my perspective and so helpful to our community. So thank you for being on the cutting edge with our response to COVID.
Thank you.
Thank you.
Everyone's worked very hard, and we have not, forgotten or discounted the behavioral health aspects of this and the impacts that is occurring Dr. Jones and I did a virtual, I guess, a Facebook meeting a couple of months ago, right, probably in the beginning of the emergency declaration to talk about the impact on those who are suffering from substance use disorder or mental health ailments. So this is not something that is lost on me, and I know behavioral health and the entire health department and the administration generally. So we appreciate that. And I want to say that this virtual meeting of the commission, we actually have the most, the most commission members present for this since probably our first meeting, very first meeting. So, telehealth works just like telecommissions work. So we have a lot more participation. So I just want to, thank everyone again and remind those who are watching from the outside that you can find the public testimony on our website, and that would be ltgovernor.maryland.gov/NBH Commission. And those who want to submit additional testimony or some testimony or comment can submit it at that website. If it's done by 4 o'clock tomorrow, the 24th, it will be put up as part of the minutes to this meeting. And again, I want to thank everyone for their participation. And I'll say thank you. Oh, and our next meeting is currently planned for August 25th, and we will likely be doing this virtually again. And we invite everyone. We'll look to see if we're able to accommodate the public coming in virtually as well with their comments. So we'll have to see how we can maneuver that through the technology and making sure that we can hear from people without sometimes going way too long, and seeing how we can handle that whole process. But thank you all.
Thank you.
Thank
Thank
you
you very much.
for your leadership.
Thank you.
Everybody.
Stay safe.